Thank you, everybody. It's great to be here in Houston. Thanks to the chairs and the organizers. Harry, I think that this is the most important talk in this session, so we'll see. But in all seriousness, to have a session on BCL-2 inhibition and AML at a meeting like this is really emblematic of the progress that's been made in this field, and importantly, it's a testament to the years of work of many people, many of them right here in Houston at MD Anderson, who were able to bring this concept from theory to reality. So it's just a real honor to be asked to give this talk, and it's really not hyperbole to say that I'm truly standing on the shoulders of giants with respect to this topic. So what I want to accomplish today is to discuss the mechanism of BCL-2 and its rationale for targeting, talk about the preclinical data supporting BCL-2 as an AML target, discuss the pre-Vanetta Clacks clinical trial efforts to target BCL-2 in AML, and then discuss some of the Vanetta Clacks data in AML, and then, of course, at the end, to predict the future. That was a joke. So just by way of introduction, BCL-2, the B-cell lymphoma 2 gene, was first discovered or appreciated by our lymphoma colleagues as being an important gene that was disrupted at the 14-18 translocation in B-cell lymphomas and resulted in overexpression as a result. But when you go back and look at the literature from many years ago, there was some surprise that this didn't result in a proliferation event, but instead impaired cell death. And now we know that this is nearly universally overexpressed in many B-cell lymphomas. And back to the impairment of cell death, we now know that multiple BCL-2 proteins, protein family members, of which BCL-2 is a member, are involved in this highly regulated cascade of apoptosis, with the anti-apoptotic proteins sort of sequestering and preventing activity of the pro-apoptotic proteins, and then these BH3 proteins in the middle mediating, and that's sort of an oversimplified view. But so what's the rationale for targeting BCL-2 in AML? Well, certainly there's lots of evidence and data to suggest that apoptosis is deranged in AML. And also, we know that BCL-2 overexpression is a poor risk factor in AML and is associated with poor response to intensive or conventional chemotherapy. But we also know that unlike B-cell lymphomas, BCL-2 is not universally overexpressed in AML. So what could be an additional rationale for targeting BCL-2 in AML? And the answer to that question, in my view, really begins about a decade ago right here in Houston, the work of Marina Konoplya and her group, who looked at, this is data from one BCL-2 inhibitor, but she did this with another one as well, showing preferential toxicity to the leukemia stem cell compartment, as opposed to cytarabine in most of the primary patient samples that she studied. Here is shown 6. Several years later, Craig Jordan expanded upon this a bit with some mechanistic data, showing first that the leukemia stem cell population resides in the ROS-low population of the leukemia cells, and this is functionally defined as the population of cells that can engraft an immunodeficient mouse model. When you look at ROS-low versus ROS-high gene expression profiling, you can see that one of the features that differentiates these two populations is BCL-2 overexpression. BCL-2 is upregulated in the ROS-low or leukemia stem cell compartment. And then taking this to its logical conclusion, if you target BCL-2 with a BCL-2 inhibitor, you can preferentially knock down or inhibit the leukemia stem cell population. So, we're going to talk about Vanetta Clacks, but there's a whole body of literature of BCL-2 inhibition in AML before Vanetta Clacks, and I'd like to just review that briefly here. The first effort that was brought to the clinic was oblimersen, which is an antisense oligonucleotide, and this work was really led mostly by Guido Marcucci, and there were 3 sort of single-arm studies that looked very promising for BCL-2 inhibition, usually in combination with chemotherapy in several different settings, but the phase 3 study was negative with respect to clinical benefit there. Moving on to Vanetta Clacks, which is a less specific BCL-2 inhibitor, but a BH3 mimetic like Vanetta Clacks. And much of this clinical work was done here at MD Anderson as well, and not terribly exciting clinical results in AML, MDS, usually as a single agent in those clinical trials. Which brings us to Vanetta Clacks. So where does Vanetta Clacks fit in? Well, once again, these are the anti-apoptotic BCL-2 family member proteins. Here are their natural BH3 proteins that bind and regulate them. And here are the BH3 mimetics. And so you can see that there are a lot of non-specific BH3 mimetics, a lot of weak mimetics. And then you have Vanetta Clacks, which is very specific to BCL-2 and a very strong BCL-2 inhibitor. So the first effort to use Vanetta Clacks in the AML setting was done in the relapsed refractory population as a single agent. And you can see here that there were responses, but it wasn't the most active agent that any of us have ever seen. About a 20% response rate in this population. And I'll never forget the final conference call for the clinical trial, the investigators. One of our colleagues sort of started to give a eulogy for Vanetta Clacks. Well, we tried 20%. That's about what we get with anything else that we've ever used in relapsed refractory AML. Let's move on to the bigger and better things. And in my head, and I'm sure other people, we were saying, no, this is just the beginning. And why did I think that? The reason for that is based on this data that's now been published, and this is a collaboration between Craig Jordan and Mike Becker in Rochester. So this is data to look at the leukemia stem cells in paired samples between upfront treatment patients and patients at relapse. So at the time of diagnosis, before exposure to any kind of treatment, if you do a functional study to define the leukemia stem cell population, again, what can engraft an immunodeficient mouse model, you find that the immunophenotypically defined populations that you would expect to contain the leukemia stem cell population contain it. So the CD34 positive subsets. At relapse, after exposure to induction chemotherapy and failure to cure the disease, it's a whole different story. And this is quite scary, really, when you look at it and appreciate it. The heterogeneity of the leukemia stem cell population after exposure to induction chemotherapy goes way up. And I'm not showing you this either, but the numbers of leukemia stem cells also goes way up. But you can see here, you're having leukemia stem cells existing in immunophenotypically defined populations that should have no business having leukemia stem cells, like CD34 negative populations. So it's quite humbling to think that any truly leukemia stem cell directed therapy in the relapse setting could be effective when this is the impact you've had on the leukemia stem cells. Much more encouraging to think about moving it into the upfront setting. Unfortunately, that's what happened with Vanetta Clacks. A study was designed, a dose escalation expansion study with untreated, unfit elderly AML patients to receive Vanetta Clacks plus a hypomethylator backbone, either decitabine or azacitidine. And here are some of the results of clinical efficacy from this study. And here we are very encouraged. So with 100 patients from the preliminary results of this study, you can see a CR/CRI rate of about 70% that sort of approximates induction chemotherapy in a younger patient population, but without a lot of the toxicity. So very encouraging activity when you move up into the upfront setting and combine with hypomethylators. And then you can also see the durability and the overall survival. Again, this is preliminary early, but also very encouraging in this setting. I'd like to take a moment just to share with you our own internal institutional data of our experience with this combination. We enrolled patients onto the azacitidine arm of the Vanetta Clacks study and enrolled 33 patients. Here's the baseline characteristics of the patients that we enrolled. But most importantly, I want to kind of show you the top line response results here. So we had a tremendous response rate, so 91%. Truly only one patient who completed a cycle, there were 2 patients who only completed a couple days. Everybody else except one patient who completed at least one cycle achieved a very significant response, and this patient even had a very significant reduction in blast count. So very, very encouraging activity in our experience. And then here's some of the follow-up data. Response duration, progression-free survival, overall survival. Medians of these have none of which have been reached, and all look very, very encouraging. I've given you some means just for reference there. We looked for traditional response predictors to this population, cytogenetics, molecular features, small study, but didn't find anything, as you would imagine, with 31 out of 33 responders. But importantly, 5 out of 5 patients with a monosomal karyotype, 5 out of 5 patients with a FLT3, 2 out of 2 patients with a P53, all achieved complete remissions. And I hope to be able to talk more about this at this year's ASH, but by using a very sensitive digital droplet PCR assay for MRD, which gets us to at least 0.01% or less, depending on how much DNA we have, we were able to design primers for 22 out of the 33 patients on the study, and we had MRD negative responses in a large number of these patients down to this super, super low level. What's more, progression was rare. We had 4 relapses in our cohort. 3 of 4 occurred after discontinuation of therapy for a variety of reasons. Only 1 patient actually progressed who remained on treatment, and that was after a remission that had lasted for 13 months. So what are the questions that we would like to answer here? What accounts for the potency of this combination? Is it something about this, especially compared to the history of other BCL-2 inhibitors? Does it have something to do with the specificity of Vanetta Clacks? Is it moving it into the upfront treatment setting? Is it the hypomethylator backbone? And if so, is there one particular hypomethylator that may be better? Is there more to this mechanism than promotion of apoptosis? I think I've tipped my hand in telling you that I think that there is. But just for a second, if you just theoretically think about what a leukemia stem cell directed therapy could result in a clinical trial setting, you could imagine it would be more effective in the upfront treatment setting than the relapse setting. It would work independent of any biological risk predictors, cytogenetics, any of those traditional predictors for response. It would get deep responses, durable responses, and a truly leukemia stem cell directed therapy should allow for the possibility of a curative therapy without a transplant. So more to come on that. What drives resistance to this regimen, I think, is an important question. And can we extend these results to other populations? What prevents us from thinking that younger patients couldn't benefit from this strategy just as much as these older, untreated, unfit AML patients? Older patients don't have more BCL-2 expression than younger patients. There's no, and all these patients were intermediate or high risk based on cytogenetic or molecular classifications. What about MDS? That's an ongoing question. What about other BCL-2 inhibitors? I think there's, there are others that are out there and present some opportunities. So with that, I'm going to conclude and just, always want to make sure to recognize that this is a very large effort. At our institution, here are some of the folks that I have the pleasure to work with, both on the laboratory side and the clinical side. And so thank you very much for your attention, and happy to take questions at this time.